All right, welcome to this high-yield explainer on foot fractures. Whether you're cramming for an exam or just need a quick clinical refresher, we're going to jump right into the essential red flags and management principles you just can't afford to miss. So how are we going to tackle this? Well, we're going to frame our entire discussion around this one key question. For each major fracture, we'll zero in on the clinical pearls, the stuff that really makes the difference between a good diagnosis and a great one. So here's the game plan. We're going to take an anatomical approach, moving from the back of the foot to the front. We'll start with the talus and calcaneus, then work our way forward to the metatarsals, and finish up with the toes. Let's dive in. So first up, let's talk about talus fractures. And you'll see how the unique anatomy of this bone is both its biggest strength and, frankly, its greatest weakness. Understanding this is absolutely key to getting why its fractures are so risky. Okay, this number right here, this is everything when it comes to the talus. A whopping 70% of its surface is cartilage. And get this, it has zero direct muscle attachments. What that means is its blood supply is incredibly fragile, depending on just a few small arteries that can get knocked out super easily in a fracture. And that, of course, leads us straight to the number one boogeyman of a talar fracture, avascular necrosis. Because of that vulnerable blood supply we just talked about, any displaced fracture can basically just sever the blood flow. That causes the bone itself to die, which can lead to a really debilitating arthritis down the road. So what's the bottom line here? It's simple, really. You absolutely cannot tolerate any displacement in a talus fracture. You have to think of it as a surgical emergency. You got to get in there with an ORIF, open reduction and internal fixation, to restore that anatomy and, most importantly, to save that fragile blood supply. Okay, let's shift gears and move to the calcaneus, the most commonly fractured tarsal bone. These are your classic high-energy injuries, usually from a major axial load. Think of the classic lover's fracture, from someone jumping out of a second-story window. All right, listen up, because this is a huge, non-negotiable point. The very same force that's powerful enough to shatter a calcaneus can shoot right up the spine and cause a lumbar compression fracture at the same time. So if you find a calcaneus fracture, you have got to examine the spine, period. Missing this is a classic, and I mean major, pitfall. So when you get that lateral x-ray, the key measurement you're looking for is the Böhler angle. It basically tells you about the relationship between the front and back of the calcaneus. If that angle is reduced or flattened out, it's a dead giveaway that the posterior facet has collapsed, and it tells you you're dealing with a much more serious injury. Now, while surgery is often the go-to for displaced fractures, hold on, because not every patient is a candidate for osteosynthesis. That's the surgical fixation. Things like poorly controlled diabetes, peripheral vascular disease, and especially active smoking are huge contraindications. The risk of wound complications and infection in these patients can be, well, absolutely catastrophic. Okay, let's head into the forefoot now and talk about metatarsal fractures. And with these, the mantra is really location, location, location. Where the bone breaks makes all the difference for the risk and the management plan. Okay, you're going to want to really dial in on this one, because this is a classic board exam question. You have to know how to differentiate a true Jones fracture from other fifth metatarsal fractures. A Jones fracture happens right in this nasty vascular watershed area at the metaphyseal-diaphyseal junction. This means it has a super high rate of non-union, and because of that poor healing potential, early surgical fixation is often the best bet. So for the other metatarsal fractures, the guiding principle is all about stability. If you've got significant displacement or if multiple metatarsals are broken, the structural arches of the foot are in big trouble. If that happens, surgery is pretty much a given to put that architecture back together and prevent long-term problems. And last but not least, let's talk about the toes. Now, these are super common injuries, but thankfully, the management here is usually way more straightforward. Yeah, for the vast majority of toe fractures, the treatment is super simple and functional. You just buddy tape the broken toe to its neighbor for stability and put the patient in a rigid-soled shoe to protect it while it heals. Surgery, that's really the exception, not the rule. You really only think about it for a badly displaced fracture of the great toe, just because of how important it is for pushing off when you walk. All right, let's wrap this up and pull everything together into one high-yield summary. These are the absolute must-knows, the take-home messages you need to have locked in. So this table lays it all out perfectly. For the talus, it's all about that fragile blood supply and the risk of AVN. For the calcaneus, think high energy. And for goodness sake, check the spine. For the fifth metatarsal, remember the Jones fracture and its poor healing. And for most toe fractures, remember that conservative treatment is king. So as we wrap this up, the big takeaway is that not all foot fractures are the same, not even close. Each one has its own unique risks and demands a specific approach. Being able to spot these key patterns and red flags is what really separates a novice from an expert. The real question is, which of these red flags are you going to carry with you into your next shift?